Okay, we'll call this meeting to order. We have everybody here, so can I get a motion to approve the agenda? Thank you. All in favor? All in favor of approving the agenda? Carried unanimously. Are there any declarations of pecuniary interest? Mayor Davis. Okay. We move into a motion to adopt the minutes of the previous meeting. Councillor Miller, seconded by Councillor Hunt. Any errors or omissions? Seeing none, all in favor? Carried unanimously. Is there any business arising from the minutes? Seeing none. Staff reports. Can I get a motion to put staff reports on the floor? Councillor Bell, seconded by Councillor Miller. Okay, Russ, did you want to speak to this first before we open up for questions?
Through you, Mr. Chair, I believe everybody's had an opportunity to look at our statistical report, and things have basically deteriorated to some extent since our last report. Since we last met, the Ministry of Health and the Deputy Minister is now aiding our service in trying to help out with our offload delays. Currently, we are not one of the or the worst offload delays in the province of Ontario, and the ministry has basically sent the Deputy Minister and their team in to help us correct this issue. Deputy Chief Kevin Robinson and myself have had multiple meetings. General Manager Cindy Stevenson has had multiple meetings. We believe that there's a better course of action to be taken and to help us out. If you look at the amount of times that we're used for extensive offload delays, we cannot manage the service. We continuously get called to say, we're having a bad staffing situation today, we're overwhelmed with beds, you better upstaff another truck just to maintain coverage within our community. We continuously rely on our neighboring services, Norfolk, Six Nations, Oxford, Hamilton, Waterloo, to do calls in our area. They've put a few different people in charge, but finally the new CAO, we met with Bonnie Cam yesterday, and she's committed to get the problem corrected. It's not going to happen overnight, but the ministry also assured us that they are not leaving till we're on the right path of improvement. The Ministry of Health has but assisted very strongly with London and other areas, including Hamilton, and they've gone from, say, 60th down to 22nd in the province for offload delays. There's a lady by the name of Andrea Innes from North York General Hospital. She's one of the director of emergency services over there. The province has asked her in multiple jurisdictions to come in and provide a change, not in culture, but information of underlying situations like who is responsible for that patient when they cross over the line, who has the overall responsibility once treatment is started within the hospital. And Hamilton brought her in, and Jaravinsky was, I think, 68th in the province. Now they're 9th in the province for offload delays. If you like an overview of what Andrea talks about, Deputy Chief Robinson can speak briefly after question period just to give us an overview. We have asked her to come into our area to help us, and the hospital has agreed to meet with her as well to take her recommendations. The one good thing about the province coming in right now, what has worked in other jurisdictions, they're attempting to apply them to Brant and the county of Brant right now to help us out. The statistical package, I would be glad to answer any questions regarding that if there's any questions from the floor, but I just wanted to give you an overview of what's happened since the last time we met.
Okay, is the construction at the emergency part of the problem with offload delays, or is it not really affecting things?
To you, Mr. Chair, I would say it's about 5%.
Okay. Questions? Yeah, Councilor Pearson.
Through you, Mr. Chair. Russ, when you've got the call time and offload delays, you've got the chart there on page 11. And I'm just curious, if you go back to, even back to 2018 is kind of where I went back. And there seems to be approximately, if you compare time on task to hospital offload times, it seems to be about 35-ish minutes difference. Is that to do with and I'll get into the who's responsible and all that kind of stuff. So once the patient has been, we'll say offloaded, it's now the hospital's responsibility. Is that 30 minutes to clean the unit, or is that done at another time? Is that included in that, or that's just strictly the time on task is just that waiting for that patient to be offloaded?
The time on task is everything combined.
Okay.
What you do not see is the allotted 30 minutes that every call comes in. So once I bring you in, we have 30 minutes to offload, do our transfer of care and patients, right? That is not calculated into the hour and 16 minutes. So that's above and beyond the allotted time that we are allowed to, or basically recommended from the ministry, to be able to offload a patient and get out there. And it also includes cleanup time for our vehicle. So that 30 minutes there, you do not see in any of those calculations.
If I could, Mr. Chair, so just to clarify that, so are we saying that there would actually be an additional 30 minutes to that hour and 16, or that cleanup time that we don't see per se is within that total time on task?
So it would be an additional 30 minutes. We don't start adding on to offload delays until after that case.
Okay.
So again, bringing somebody in, the ideal scenario, bring them in, tell the nurse, put them in a bed, give you a report, clean up your vehicle, and you're turning around out the door in 30 minutes.
Right.
We've ran our stats, and I've said it before, if they could manage us down to 90 minutes right now, complete on every call, we could basically manage the service. Right now, we're sometimes pushing over 2 hours per call, as it states in the reports.
Right. Okay, and I appreciate that explanation. So that kind of brings me into my next question, which you kind of alluded to earlier. So if we look from 2023 to 2024, there was a little bit of, like, we actually got a little bit better in 2023, but then from 2024 on, and we talk about, when you said there's a thing going now, who's responsible for the patient at what point in time and that sort of thing. So to me, and you've discussed it before about, the staffing at the hospital and stuff like that, I don't want to assume, but is it safe to assume that additional, in essence, almost 30 minutes is due to the fact of lack of staff at the hospital?
To you, Mr. Chair, it's a multiple of things. It's staffing. It's inability to have other long-term care beds out there in the community.
Right.
Not having enough doctors to have access. As I said, we met with Bonnie Cam yesterday, the CEO. It's a multiple of figures, but we're experiencing it the most right now because when they have a surge in beds or they do not have room upstairs, they start backing up the ER department. We've come in on many nights that our beds that we've been allotted or basically paid for the offload nurse or backhaul nurse, they're already filled with admits to no bed, and we have nowhere to go.
Okay.
So it's just like whatever plugs up upstairs, it starts pushing us down to our emergency department.
Right. And one final one, Mr. Chair, and I'm glad you kind of put it that way, Russ, because it'll be very interesting to see what the province or minister, whoever's coming in now. It'd be interesting to see that report because I think I can speak for everybody here. We know that you guys are doing everything you can, but you are not the hurdle here. The hurdles are once you get there and beyond, just to your point, whether it's beds, whether it's staff, whether it's that. So it'll be interesting to understand the recommendations, we'll call it, that they come back with, because the only recommendations I can see that are going to help here is A, more beds, or B, more staff. But even if you had the more staff, it's the beds that are the bigger backlog because you haven't got anywhere for patients to go.
May I? Through you, Mr. Chair, it's the culture that has been developed at the hospital that needs to change, that's going to make the biggest impact that we currently have right now. We have said it, and I've said it even to the CAO yesterday, we're not basically part of the team. We're just basically a temp agency helping out your shortfalls and your stuff because you are overwhelmed. We need to be brought to the table when you develop policies. We need to be able to provide our input on change. We need to be able to work with them as a team rather than just relying on us as extra pairs of hands, monitors, beds, or whatever the case is. And I've said it many times, we need to be there before any other policies are developed. Like myself and Deputy Chief Robinson enacted a diversion policy with Norfolk General because at that time in 2018 and 19, Brantford General Hospital had no interest in it. They're now talking to Oxford to do diversion, but they're talking and it's not including us. And we've now told them, it says we need to be at that table too, because now we need to speak with the people in Oxford, the chief and everybody else out there, that we're now going to be coming into your area until these things have changed in Brantford. But we need to speak, say, our language rather than you just basically deciding what's best for us.
Good on you for that, Russ. And I think I can speak for our two mayors that are here that they'd be more than happy to help push that if they could.
Thank you.
Thank you.
Councilor Miller.
Thank you, Mr. Chair. Through you to Russ. Russ, it's so disheartening to see this report. In the hospital offload time to go up that much, that quickly. And I knew as soon as I seen that metric that everything else would be negatively impacted, and it was, whether it's the number of code zeros, the number of ambulances coming into our municipality. It's going to impact the bottom line for the budget. It's just so many negative things come from that number. And we did have BGH make a presentation. They had the head of their emergency department, I want to say Dr. Ahmed. It was everything we told her. I mean, there shouldn't be nothing new to her. I don't know if she knew exactly how much it was costing us per hour for ambulance time, but we know it's significant. You said last time it's about $150 an hour. So all the metrics, all the stats negatively impacted, but not included in here. And I wanted to ask you, because I know myself, when I get really busy, I get a little more stressed. What's the impact? Is there any noticeable impact on the ambulance service members' morale or stress levels from when you see those things go so south so quickly, as far as wait times and all that?
Through you, Mr. Chair, yes, morale is significantly impacted. We only can do so much for working with a third-party agency. Our crews are standing there. They come in at the beginning of the day, and they basically work their way through, miss their lunch meal breaks, as you've seen some of the budget stats and all that, right? Somebody asked a question and says, how many times do nurses miss meal breaks at the hospital? And they said they can't, they're unionized. So that's very disheartening for our crews, standing there and waiting for a bed, and then we say, can we have that bed? No, not till the nurse comes back from break, right? So we're standing there helping. This is why we want to be part of the solution. Our crews deserve the same break times, and we need to put either, I'm saying partially ambulance resources because it's our call volume going up, but we can't keep throwing money at a situation. As you've seen in this budget report, the extra cost of staffing was a result trying to keep the community covered during those times. And we just can't give them that money and $628,000 for offload beds and $250,000 for a dedicated offload nurse. But the morale, I would say, would be one of the lowest it has been, just because it's like ongoing every day, 24/7. And I don't want to say this in the wrong sense, but they need downtime too to decompress. Like even with our overtime in previous years, and Deputy Chief Vanderpost came up with the idea, we were spending $35,000 a year on taxis to pick up our crews at base at night, to shuttle them over, to relieve that crew, but we were paying so much in overtime. So with his idea, we ended up buying leasing 4 RAV4s at the bases, so the nighttime crews can come over there. We're not paying taxis. We have these vehicles, and our overtime costs went down. Your costs that you see in this report are more for staffing of additional ambulances, but we have to come up with innovative ideas to make sure our crews get home rather than they're on a 7 to 7 and they get home at 10:30 at night, right? We're trying to come up, we're trying to improve the morale, but it's a long way off.
Thank you. Like I say, I mean, we see the numbers, but it goes beyond the numbers.
Correct.
And we got to deal with the fallout, obviously, from the budgetary, and that's hard too. But I appreciate the answer. Thank you.
Here it is.
Yeah, I want to thank the county council. I'm not sure I can add much, but I share their sense of frustration and sympathy for our paramedic staff, but also, you know, the line staff of the hospital. I'm sure it's not a great situation for them either. But so we've seen it over the course of just 12 months. It's deteriorated like by at least 50, 60%, which is just, it's incredible. I assume the staffing levels of the hospital are essentially the same over the last 12 months.
Through you, Mr. Chair, they have improved slightly, but again, it's hard to retain and bring more nursing staff in.
Right. So is there any other factor at play here?
Through you, Mr. Chair, not that I could think of at this time that would be basically a factor that's going on, except for what they told us yesterday, the increase in long-term, the inability to have people going to long-term care facilities. The hospital's ALC has increased access to doctors in the community. So it's a compounding problem, not just at the hospital itself.
Yeah. And the fact that the hospital hasn't had a permanent executive director for over 13 months, I think that's a factor too.
Through you, Mr. Chair, that is correct. I think with new leadership there, new ideas. As I said, Bonnie came from Grand River. She's been in through the system in Toronto at Peel and other areas. We had a meeting with her yesterday, and she does have an action plan to move forward, but it's going to take a couple months for her to get her feet wet and move things on.
Yeah, well, certainly I wish her the best and hope that her hiring and now her, because I've met her as well, I've been very impressed. And it's very encouraging to hear that the ministry as well is taking this very seriously and appointing facilitators to assist in resolving the situation. And again, as Councillor Pierce said, if there's anything we can do at the city, just let us know. We're happy to help out.
I appreciate it. And through you, Mr. Chair, when we were on the ministry, we basically, our biggest focus is we cannot continuously throw money to this scenario without having the appropriate people helping us. And the ministry did state they're not leaving until the ship gets pointed in the right direction.
When paramedics are waiting for offload, does one go and clean the ambulance while the other stays with the patient, just to speed things up so they're ready to go once the patient is offloaded?
Through you, Mr. Chair, in most cases, they will work out a way to expedite themselves out of there. Sometimes, depending on the acuity of the patient, they would both have to stay with them.
Okay, but when only one needs to stay, then the other one cleans to get things ready to go.
The crews don't want to be there any longer than they have to.
Yeah, it's got to be rough on them too. Okay, seeing no further questions or comments, we'll call the question. All in favor? Carried unanimously.
May I add one more thing?
Absolutely.
Through you, just another thing I forgot to tell you is for lost hours in the emergency department, halfway through the month of April, we lost 1,091 vehicle hours, 96 code zeros. These just came in. My admin assistant just printed them off for me this morning. And we're, on average, I'd say we're over about 1,000. And basically for ER lost hour, it's just like right now into the first 5 days of May, we've lost about another 250 lost hours, and that's not a calculation. I can have this circulated again, but I'm just saying she just printed this out for me this morning.
Okay, brings us to 7.2. Budget to actual variance. Have a mover put it on the floor, please. Moved by Councillor Pierce, second by Councillor Miller. Floor is yours, Russ.
Through you, Mr. Chair, the variances were as outlined. We had a decrease in the overall cost of training, but our fuel costs, our biggest hit was our man hours to try to make sure that the community was covered, and our overall vehicle maintenance, as our vehicles were delayed until late November, December, arriving from last year. We anticipate this year to be on budget. We're trying to limit our upstaffing to the best of our ability at this point in time. And I think the biggest problem that we may have with some of the things like fuel costs and the cost of maintenance is we're doing our budgets. This budget was done in June, forecasting 18 months out, and that was part of the variable. If you have anything dealing with exact figures, I would ask Heather Mifflin to address any questions you may have.
Questions? Councillor Miller.
Yeah, thank you, Mr. Chair. And through to Heather, when we get a deficit like that at the end of 2023, how do we fund that? And I know we fund it through property taxes, but how do we? Where do we pull that money from?
Through you, Mr. Chair. It will come out through the overall surplus for the county share. The city share will be invoiced to the city to pay, and it will again flow in and out through the general surplus for that year.
Okay, and I appreciate the answer because I know we play with that surplus maybe more than we should. So, okay, thank you.
Thanks, Mr. Chair, through you to Russ. As far as the training, that was one of the things that jumped out at me there. Is there rationale from the ministry why it wasn't available, or is it just like, is it across the board, or just to us, or what? Like, why?
Through you, Mr. Chair, the ministry requests us to have 80 hours available for advanced care training, 44 hours for primary care training. In most years, they utilize it. Last year, they did not. So there was no training program set for 2023 that we would be able to use those additional dollars. For example, if the ministry says we're going to be doing a course on labor and delivery or whatever the case is, right? We have to have the hours available readily into our budget rather than asking the ministry for additional funds. It's just a baseline that we have for training. But last year, 2023, there was no ministry training set aside.
So, through you, Mr. Chair, sorry, Russ, there was no ministry training, or there was no funds for ministry training. I'm just trying to understand.
So there was no set ministry training. We have to forecast it in our budget so that when the ministry comes out with, say, the 2024 training package on labor and delivery courses, we have to have that money currently in our budget for what they have. So a primary care paramedic gets their service CME, their base hospital CME, and normally another 8-hour course, along with other courses at the same time. ACPs have a requirement of a certain number of accredited hours, almost like a nurse, to get done. But this year, the ministry, or in 2023, the ministry did not have an additional course for us to do. That's the only difference why we had a negative on training.
Okay. No, I was just curious as to how that. Thank you.
Seeing no further questions or comments, call the question. All in favor? Carried unanimously. Okay, are there any communications? No? Other business? Okay, need a motion to go in camera. Moved by Councillor Miller, seconded by Councillor Pierce. Oh, sorry, Councillor Hunt, okay. This is regarding a position plan